double-edged sword, please.
Thank you very much. It's a pleasure to be here, and I'm very grateful to the organisers for the invitation. So these are my disclosures. And I'm going to follow on from Dr. Brandenburg and talk a little bit more about neprilysin inhibition, which may be a therapy which people in the room aren't quite so familiar with, and whether it's a double-edged sword, and by that I mean whether it can be good for the heart and possibly also good for the kidney. So my introductory slides I could probably skip over now after those introductory talks, but we know that patients with heart failure are very likely to have chronic kidney disease, and we know that that has a significant impact on their prognosis. So these are data from some of the early trials of angiotensin receptor blockers, the CHARM series, showing the outcome in people with reduced ejection fraction and preserved ejection fraction. These were before the days that MREF was introduced, showing the strong impact that the worse your kidney function in those trials, the worse your outcome in terms of cardiovascular death or hospitalization for heart failure. So we've known for a long time that kidney disease has a strong impact on the prognosis of people with heart disease. We also know that the reverse is true, that heart disease is very common among patients with chronic kidney disease. These are relatively simple echocardiographic data published some years ago now, but showing that as kidney function declines, so the prevalence of structural heart disease, in this particular slide, the prevalence of left ventricular hypertrophy, increases quite steeply. And we know that patients, by the time they progress through kidney disease to start dialysis, the vast majority of these patients will have an abnormal echocardiogram. And more recent use of cardiac MRI shows that these abnormalities actually begin very early during the progression of chronic kidney disease, and that subtle abnormalities in heart function are detectable in patients with quite early chronic kidney disease. And what's particularly important is that the patients are often asymptomatic from this point of view, so they may not come to the attention of a cardiologist. They may just simply be in a nephrology clinic or even just in primary care, but essentially these patients have some degree of heart failure or structural heart disease, even if it's not apparent clinically. So there's a strong overlap then between the heart and the kidney. This is a slide adapted from the European guidelines, which Dr. Brandenburg showed you, showing the huge amount of evidence-based therapy that there now is for patients with heart failure and reduced ejection fraction. Nearly every patient will require diuretics, and then above that it's built on a foundation of the combination of beta blockers, ACE inhibitors, mineralocorticoid receptor antagonists. Above that, there may be some implantable device therapy, such as ICDs or resynchronization therapy. And then beyond that, we have mechanical support, whether that be transplantation or left ventricular assist devices. But recently in the cardiology world, there's been some debate around whether there is now a new challenger on the block to replace this central stone in this whole management strategy, as to whether ACE inhibitors, there is actually now something superior to ACE inhibitors. So I want to introduce you to a trial which was published just under 4 years ago now, called the Paradigm Heart Failure Trial. It was the largest trial ever conducted amongst patients with heart failure and reduced ejection fraction. And it tested a drug called LCZ696, which has a new name now, which is sacubitril valsartan, and compared that with enalapril in over 8,000 patients with heart failure and reduced ejection fraction. And they used the classical primary outcome of hospitalization for heart failure or cardiovascular death. The reason the trial was so large, however, was partly because they were comparing it was one active agent versus another active agent, but also because when they worked out how many patients they wanted, they based it on just detecting a difference in cardiovascular death alone. So they ended up with a very large trial, which is partly the reason why we have such clear results. And over here on the right-hand side, you can see the primary outcome. And you can see that those patients assigned sacubitril valsartan, or LCZ696, were at 20% lower risk compared to people already on optimal heart failure therapy, including enalapril, of the risk of hospitalization for heart failure or cardiovascular death. And in fact, if you looked at this slide and just looked at the effect on cardiovascular death alone, you saw a very similar reduction, 20% reduction of cardiovascular death alone, which translated into an all-cause mortality reduction of 15%. And that's why this trial has caused such a stir in the cardiology world and made people think that maybe we need to replace enalapril now with sacubitril valsartan. So what is sacubitril valsartan? Well, it's the first in class, and in fact the only in class currently at the moment, of a new type of drug called an angiotensin receptor neprilysin inhibitor, or ARNI for short. So neprilysin, which is also known as neutral endopeptidase, which is widely expressed in the kidney, particularly in the proximal tubule, is responsible for degrading natriuretic and many other vasoactive peptides. So ANP and BNP are all degraded by neprilysin. And we know that as levels, these natriuretic peptides, for example, have positive associations with outcomes. So it's possible that if we could inhibit neprilysin and therefore prevent the breakdown of these peptides, that may lead to an improvement in outcome for these patients. Neprilysin inhibitors have actually been around for a very long time, but it's taken a long while to actually develop them into a state where they can be used clinically. As monotherapy, if you just give a patient a neprilysin inhibitor by itself, although it has the beneficial effect of inhibiting neprilysin, it also reflexly activates the renin-angiotensin system with obviously all the adverse consequences that brings. So neprilysin inhibitors need to be combined with an inhibitor of the renin-angiotensin system, and the first compounds that were developed to do that combine neprilysin inhibitors with ACE inhibitors, creating another class of drug called vasopeptidase inhibitors. The best example of this was a drug called omapatrilat, and omapatrilat went through a number of trials, some very large trials in hypertension and in heart failure, and was showing considerable promise in both fields. But the development of omapatrilat was discontinued when there were large numbers of patients experiencing angioedema. And some of these cases of angioedema were very serious, requiring intubation, and some were even fatal. And when the reason for this was explored, it was because one of the vasoactive peptides that neprilysin breaks down is bradykinin, and we know that ACE inhibitors also prevent the breakdown of bradykinin. Consequently, patients receiving both neprilysin and ACE inhibition got very high levels of bradykinin, and that was what caused the high rates of angioedema. Consequently, combining sacubitril or a neprilysin inhibitor with valsartan, an angiotensin receptor blocker, angiotensin receptor blockers have no effect on bradykinin, would allow these drugs to be tested in a much safer fashion with no excess risk of angioedema. So we have now a new class of drug which seems to have a very beneficial effect in the world of heart failure. It's then very logical to test these drugs in people with chronic kidney disease, because as previous talks have already shown, and as I've said, patients with chronic kidney disease are at actually very high risk of cardiac failure-like outcomes, whether or not they're known to have heart failure. We know they have structural heart disease, and the echoes of these patients will look very similar to echocardiograms of some patients with heart failure. So it's very logical to think, will neprilysin inhibitors reduce cardiovascular risk in patients with CKD, just as they do in patients with heart failure and reduced ejection fraction? We'll find out I think in a year or two's time whether neprilysin inhibitors improve outcomes in patients with heart failure and preserved ejection fraction. That's the topic of a trial called Paragon, which at the moment is still ongoing. But before we get into thinking about neprilysin in patients that nephrologists see in their clinics with chronic kidney disease, what do we know about the effects of neprilysin inhibitors on the kidney? So these are some results from some work done by Martin Thal when he was in Barry Brenner's lab. I apologize, this was published in 2001, not 2004, where they used a 5/6 nephrectomy model and observed what the effects on proteinuria were in these rats. So in the triangles, you have the control-treated rats who just had a 5/6 nephrectomy, and you can see a rapid increase in proteinuria before the animals had to be sacrificed. Other rats were given enalapril, and you can see a rapid reduction in proteinuria and then some escape, and ultimately many of these animals also had to be sacrificed. But those patients given omapatrilat, that's the combined ACE inhibitor plus neprilysin inhibitor, their proteinuria reduced further and stayed low for much longer, suggesting that the combination of neprilysin inhibition with renin-angiotensin system inhibition may prolong renal survival, at least if you're a rat who's had most of their kidneys removed. We do obviously have some considerable data on the effects on kidneys from the large heart failure trial, from the Paradigm heart failure trial that I showed you the primary results of earlier. And these results were published earlier this year. And this shows the difference in kidney function between those patients assigned sacubitril valsartan and those patients assigned enalapril, subdivided into whether or not they had diabetes or not at baseline. And you can see, regardless of whether they had diabetes, the lines in red, or whether they didn't, the lines in blue, the patients assigned sacubitril valsartan had a slower rate in decline in their kidney function than those patients assigned enalapril. So this is looking quite positive then. It may be that these drugs are actually nephroprotective as well as being cardioprotective. There was a slight fly in the ointment in the data from the heart failure trials, and this has come up in not only in the paradigm trial in reduced ejection fraction heart failure, but also in smaller trials in patients with preserved ejection fraction heart failure, that there seems to be a very slight adverse effect on albuminuria or proteinuria. So you can see here, the blue lines show the results at baseline, and then the grey bars show the results at 8 months into the trial. You can see amongst the patients assigned enalapril over here, there was a reduction in albuminuria during the first 8 months of the trial, whereas those patients assigned sacubitril valsartan, there was no change. And if you compare those two differences, you see quite a highly statistically significant difference in albuminuria then at 8 months. However, if you look at the scale on the left-hand side, this is in milligrams per millimole, so this is a very, very small difference in albuminuria. But as you can see, at baseline, these patients had very, very low levels of albuminuria, as is typical with many patients with heart failure. But this does raise an important question for people, for nephrologists, if they want to give patients neprilysin inhibitors. What would be the effects on albuminuria in patients, say, with macroalbuminuria that we see in our clinics? So it therefore seems likely that before we go embarking on giving neprilysin inhibitors widely amongst patients with chronic kidney disease, we need some more direct evidence. We know that neprilysin inhibitors seem to have preserved kidney function amongst patients with heart failure and reduced ejection fraction, but I've just shown you that they may also increase albuminuria. The paradigm heart failure trials excluded patients with an estimated GFR below 30 mils per minute, so the effects on kidney function among patients with more advanced kidney function is uncertain. And we therefore decided that before we could design a large outcomes trial to determine what the effects of these drugs were on hard clinical outcomes, we should do a pilot trial to see if we could find some reassuring data that would allow patients to be randomized into a much larger trial. And so this is where the UK HARP-III trial came in. So this was a randomized pilot trial comparing sacubitril valsartan versus irbesartan among patients with chronic kidney disease. I'll just divert slightly. We chose irbesartan as the comparator because irbesartan is the ARB with a license indication for proteinuric kidney disease, and we thought that would be considered best therapy amongst patients with CKD. Patients were eligible for the trial if they had a GFR between 20 and 45 mils per minute, or if they had a slightly higher GFR between 45 and 60, they were also eligible as long as they had some evidence of albuminuria. And the majority of these patients, over 80% of them, were already being treated prior to entry into the trial with an ACE inhibitor or an angiotensin receptor blocker. And the comparison was sacubitril valsartan. This is the official dosing of sacubitril valsartan, the same dose used in the paradigm trial. It's a twice-daily drug, compared with irbesartan, 300 milligrams once a day. And the primary outcome of the trial was a measured GFR, and we also had secondary outcomes looking at estimated GFR, albuminuria, blood pressure, and cardiac biomarkers, and then importantly, the safety and tolerability of these drugs. As Dr. Brandenburg showed you in one of his slides, in the heart failure trials, if anything, there was slightly less hyperkalemia with these drugs than with enalapril alone. But it's important we looked at that in people with kidney disease. So this was the design of the trial. So patients came to a screening visit at which their eligibility and willingness to participate was assessed. And if they were willing and eligible to enter the trial, then they actually stopped any angiotensin ACE inhibitors or ARBs that they were currently taking, and they started placebo LCZ696 or sacubitril valsartan and placebo irbesartan. And the reason that we did this placebo run-in was several-fold. Firstly, as I've shown you, as I've already discussed, there are some concerns about patients having a neprilysin inhibitor at the same time as an ACE inhibitor, and we wanted therefore to make sure that any ACE inhibitor the patients may be taking was completely washed out before they got exposed to a neprilysin inhibitor. But also because we wanted to look at also as part of the trial, look at the acute effects on kidney function of introducing these drugs and be able to compare them, and therefore we didn't want to have patients on ACE inhibitors or ARBs at the point of randomization. If after taking placebo for between 4 and 7 weeks they were still willing to participate and still eligible, they came back for a randomization visit where they were assigned sacubitril valsartan or irbesartan with a forced titration step. So patients were started on half dose, and then after 2 weeks, after a check of their kidney function and electrolytes, automatically stepped up to the full dose. And then they were seen fairly frequently over a 1-year period. At the time they came for randomization, before they received any of their randomized treatment, they had their GFR measured, typically using a chromium EDTA method. At some sites use some other methods, but they always use the same method at those sites throughout. Patients were seen fairly frequently with blood tests taken at all of these visits, and then a year later, just before they came to their final follow-up visit, they had their GFR measured again. And so we have a GFR assessed at 12 months, which was the primary outcome, and in the analysis we adjusted that for the GFR measured at baseline. So these are the sorts of patients that we recruited into UK HARP-III. We got just over 400 patients, and this was fairly typical of a UK nephrology clinic population. So their mean age was just over 60 years, and the majority were male. 40% of them had diabetes, and about half of those patients, diabetes was determined to be the cause of their kidney disease. And their blood pressure at baseline, bearing in mind that they had had their any previous ACE or ARB withdrawn prior to these measurements, was 146 over about 80. And their mean eGFR coming into the trial was 35, with a geometric mean albumin-creatinine ratio similarly of about 34. So much, much more albuminuria than the patients in the heart failure trials. And we had patients with a wide variety of kidney diseases coming into this trial. Glomerular disease, with a large number of those having diabetic kidney disease, tubular interstitial diseases. There was a very wide variety. We were deliberately non-specific. We didn't recruit just one type of patient. We wanted a broad cohort. So before I get on to show you the efficacy results, I'll show you the tolerability results. How well tolerated is sacubitril valsartan compared to irbesartan? And the short answer is about the same. There didn't seem to be any real difference in tolerability. About 1 in 6 patients stopped their study treatment, but that was the same whether they were assigned sacubitril valsartan or assigned irbesartan. And very few of the reasons for stopping treatment were actually due to serious adverse events. So it was a well-tolerated intervention, about as well tolerated as current standard of care. And here's the primary outcome then on measured GFR. So again, on the left-hand side, we have the effect of sacubitril valsartan with a mean measured GFR just under 35 at baseline. And as you can see, it dropped in both groups, unsurprisingly, as they essentially had a renin-angiotensin system inhibitor introduced in both groups. But the difference was actually, well, there almost was no difference in this between the two groups. So by contrast with the heart failure trials, at least over 1 year, there was no difference in GFR between these two groups. So that was our primary outcome, so no real effect on short-term kidney function. If we looked at that with estimated GFR, and obviously we got many more measures of estimated GFR than we could get of measured GFR, you can see the curves are basically on top of each other. There's the acute decline, as we would expect, as the angiotensin receptor blocker is introduced, and then after that there's a slow rate of decline in both groups, but it was pretty similar in both groups. There's no difference in slope, either between 0 and 3 months or 3 months to 12 months. The slopes were the same in both groups. So what about the effects on albumin-creatinine ratio, or albuminuria? Again, you can see large reductions in both groups. Reassuringly, a large reduction with sacubitril valsartan, so very different to the heart failure trials where there was actually what would have equated to a 50% increase. But again here we see, although a numerically slightly larger reduction in the sacubitril valsartan group, again actually no statistically significant difference. So the effects on kidney parameters in this trial over 1 year actually suggest that the effects of sacubitril valsartan are very similar to irbesartan, with no good evidence of a benefit over 1 year. But also certainly no evidence of harm, particularly in albuminuria where most of the concern was. What about blood pressure? The first trials, or the first large trials actually to be published with sacubitril valsartan were in the blood pressure field. And we can see here that actually sacubitril valsartan did reduce blood pressure significantly more than irbesartan, about 5 millimeters of mercury lower systolic blood pressure on average during the trial amongst patients assigned sacubitril valsartan than those assigned irbesartan. So the results I've shown you on kidney function are actually in the context of quite a significant difference in blood pressure. And we saw obviously a numerically smaller but similar effect on diastolic blood pressure in the trial. But we also were very interested in cardiovascular outcomes. We know that patients with chronic kidney disease, actually the majority of them will experience a poor cardiovascular outcome, and certainly that's more frequent in an unselected population than those that will go on to develop end-stage kidney disease. So we're very interested in the effects on cardiovascular parameters. And so we tested the effects on cardiac biomarkers, and in this case, NT-proBNP. And as you can see here, there were again reductions in both groups, but the reduction in the sacubitril valsartan group was considerably larger than that in the irbesartan group. And I believe this is the first time that a therapy in chronic kidney disease used in an unselected CKD population has actually been shown to reduce cardiac biomarkers like NT-proBNP. So almost a 20% reduction compared to irbesartan. We also looked at troponin, and we saw a very similar effect on troponin I. So this is just baseline troponin, but we know that patients with chronic kidney disease, many of them do have a slightly abnormal baseline troponin measurement, probably due to, almost certainly due to that structural heart disease, rather than being due to reduced renal clearance. And again, we saw here a 16% reduction in troponin. And we know that troponin predicts adverse prognosis in people with heart failure and people with kidney disease. We know that very well. And we know the same for NT-proBNP. So we seem to be having very favorable effects on cardiac biomarkers in this trial. And to put that into context, here are the effects on the left, NT-proBNP, and on the right, troponin T as it was measured in the Paradigm heart failure trial that I've shown you. And I would just focus on these sections here in the double-blind period of the trial. And you can see both at 4 weeks and at 8 months, patients assigned sacubitril valsartan with the white circles had substantially lower levels of NT-proBNP than those patients assigned enalapril. That was true at 4 weeks and 8 months. And similarly with the troponin, a very significant reduction in troponin levels amongst patients assigned sacubitril valsartan compared to those assigned enalapril. And we know what the effect of this was on clinical outcomes. I showed you that right at the start of the talk. The effects on these were associated with very substantial reductions in cardiovascular mortality and morbidity. So we could hope, therefore, that maybe sacubitril valsartan might have similar effects on cardiovascular outcomes in patients with CKD. So in summary then, angiotensin receptor neprilysin inhibitors, a new therapy in the world of cardiology, and possibly coming to a kidney clinic near you, appears to have no additional effect on kidney function when compared to angiotensin receptor blockers. We could view that as slightly disappointing, or we could view that as we may have wanted to see a benefit. I would say the trial was probably too small and was too short and wasn't designed to detect effects on long-term kidney outcomes. But we could also say that this is reassuring because we had patients in this trial with GFRs down to 20 mils per minute and we found no adverse effects, so suggesting that it could be used safely in a broader group of patients. But we did see beneficial effects both on blood pressure and on cardiac biomarkers compared to just being on irbesartan alone. So these results suggest that angiotensin receptor neprilysin inhibitors may well reduce cardiovascular risk among patients with chronic kidney disease, and we haven't yet excluded that there may even be a benefit on kidney function. So I'd just like to finish by thanking many people who made the UK HARP-III trial possible, and most importantly, that's the 414 participants that we had, but also the doctors and research coordinators at our 25 sites, and the data monitoring and steering committees. And thank you very much for your attention.